My name is Dr. Donna Sweetland. I'm an OB hospitalist with OBHG and I work at a facility in Illinois. I had a recent life save that I'd like to tell you about. This was a 29-year-old female G3P3 who came through the emergency room after she passed out at home, fell and hit her head, and was brought in by ambulance. She was complaining of abdominal pain. The patient had a significant history for having had a molar pregnancy approximately 9 months previously. She had a D&C by her local physician, and when her beta HCG did not drop down to 0, she had a repeat D&C. Similarly, it did not drop down to 0, and so she was referred to a specialist gynecologic oncologist who performed a third procedure on the patient and actually talked with her about giving her chemotherapy agents if the levels wouldn't drop down to 0. They did 2 months prior to her current ER visit, and she was placed on oral contraceptives to prevent pregnancy. With the patient's fall and with her abdominal pain, the ER staff checked a pregnancy test and that was negative. They checked a CT scan of her head, which was normal, and they checked a CT scan of the abdomen and pelvis, which revealed a questionable 10 centimeter mass adjacent to the right side of the wall of the uterus and the question of a small amount of free fluid. The ovaries were not seen well on CT scan. They consulted the OB hospitalist group and I came down to see the patient. On talking with her, she relayed this information about her history of the molar pregnancy. And then she also relayed the discomfort that she was having on exam. And she had some rebounding guarding findings. At that time, she was hemodynamically stable, although she was a little bit tachycardic. I requested that she have a stat ultrasound to evaluate the ovaries. I wanted to make sure that they were not consistent with a hemorrhagic ovarian cyst or blood in the peritoneum. She went for that, and as she was there, I called her specialist to see if I could ascertain more information regarding her history of the molar pregnancy, because in the CT scan, when I read it, the radiologist made comment that the location of the mass was very similar to the mass seen earlier in the process when she was undergoing this workup for the molar pregnancy. On talking with the oncologist, they really wanted her to be transferred to their facility for them to further evaluate this, but their ER was on bypass and their hospital was on bypass. I subsequently then had the patient come back from the ultrasound and got called that there was an ectopic pregnancy suspected on the right side, and there was a large amount of hemoperitoneum on ultrasound. At this point in time, in going back and seeing the patient, she now had become hypotensive. She was more tachycardic, and the decision was made to take her emergently to the operating room. And at the time, she was found to have hemoperitoneum with 1,200 cc's of clot in her belly, and she was found to have a ruptured right ectopic pregnancy. The uterus itself looked normal. The patient underwent the procedure. She did get transfused packed cells as well as fresh frozen, and her postoperative recovery was without complication. She stayed overnight and she was discharged home the next day. I find this case to be very interesting in that it was somewhat confusing with her history of the molar pregnancy, and with having had a negative pregnancy test. I did order a beta HCG level in the recovery room, and it returned at a level of 13,000. So she truly did have a positive pregnancy test. But definitely, I think it shows that sometimes we have to investigate a little bit further, but it also shows the great care that the ER gave and how quickly ultrasound and the OR worked in order to take this patient to the operating room and help take care of her with a good outcome.